degeneration, thus maintaining an environment where we will be able to hear the presenters clearly. I'll repeat that as we have some folks coming in right now. Welcome. Those who are joining right now, we will be beginning promptly at 1 o'clock. And please.
Hello and good afternoon, everyone. Welcome to our virtual Low Vision Awareness Month seminar on macular degeneration and the latest research. I'm honored to introduce not only one, but two keynote speakers from Retina Consultants San Diego, Dr. Nikolas London and Dr. Michael Joseph Ammar. Dr. London joined Retina Consultants San Diego in 2012 after graduating from one of the most prestigious surgical training programs in the country at the Wills Eye Institute in Philadelphia. He has also authored countless peer-reviewed ophthalmology journal articles, as well as of books and chapters. Dr. London now serves as the managing partner, president, and director of research for Retina Consultants San Diego. He is also the president of the San Diego Retina Research Foundation. He is the founder and president of the Ophthalmology Society of San Diego and is the chief ophthalmology at Scripps Memorial Hospital in La Jolla, just to name a few of his accomplishments. Dr. Michael Joseph Ammar is a recent addition to Retina Consultants San Diego. He obtained his medical degree in Los Angeles at the University of Southern California, where he received the Dean's Recognition Award for Clinical and Surgical Excellence each of his medical years. Prior to joining Retina Consultants San Diego, Dr. Ammar performed and taught thousands of procedures and surgeries for retinal conditions and complex ocular trauma. He helped run the 24/7 Wills Eye Emergency Room, one of the only dedicated eye ERs in the United States. He has been involved in cutting-edge clinical trials and has authored numerous book chapters and studies. He has presented his work nationally and abroad, and he has served as a reviewer for multiple academic journals such as Retinal Cases and Brief Reports, American Journal of Ophthalmology and Retina, and is on the editorial board of Eyes on Eye Care. With no further delay, let me introduce the doctors. We will be starting with Dr. Michael Joseph Ammar. Doctor?
Thank you so much for your introduction and overly kind words. Again, I'm Michael Ammar, and I'm presenting today alongside my friend and colleague, Dr. Nikolas London. And I'll be presenting to you first about macular degeneration, and then Dr. London will be presenting more information about treatments and kind of the exciting new things on the horizon in regards to macular degeneration. I can promise you with Dr. London, we're saving the best for last. And before I jump into my PowerPoint, I just want to say what a privilege it is for us to be presenting today. Dr. London and I are both very passionate about macular degeneration in regards to advocacy, education, treatment. And so we hope that you leave today with a little bit better of an understanding as to what macular degeneration is. And we'll have some time for questions at the end to go into that further. I'm going to share my presentation now. All right. So before I launch, this is the team I'm very fortunate to work with at Retina Consultants San Diego. You can see on the left there, Dr. Nikolas London, followed by Dr. Ann Hannikin, and then Dr. Atul Jain, and lastly, myself. And we all feel very passionately about macular degeneration. And I think if we're going to talk about macular degeneration, first thing we talk about is vision. You know, this is a volcano in Maui, Mount Haleakala, and you're able to go up to this volcano and watch the sunrise. And when you're there, you're above the clouds because of the elevation, and the sun pierces through the clouds when it rises up, and it's a beautiful spectacle to behold. But I think it's hard to imagine what so many experiences, moments, memories in life are like for people who lose their vision. You know, obviously an image like this is a very different experience, and that's not taking into account work, family, independence, so many things. These are my little cousins, and They love going to the movies. That's their favorite thing to do. And I honestly get more enjoyment watching them watch a movie than watching the movie itself. But for people enjoying things with their family going through life, as you can imagine, if your vision is like that image on the right, things are going to be very different for you. So it's important to talk about vision loss and the impact it has on people. Patients with vision loss are 2 to 3 times more likely to be depressed than others in their age group. They also have lower morale, reduced self-esteem, and they can feel socially isolated. 71% of Americans aged 45 and older fear being blind more than being deaf. And 70% fear blindness more than losing a limb. A lot of times blindness is associated with independence, with a lot of the things we like to do, a lot of things we need to do. And to think of a world without that vision is terrifying. Before we go into macular degeneration, though, I think it's important to understand what's a normal eye. What's an eye look like? How does an eye work? Well, here's a schematic of an eye. And at the very front of the eye, you have the cornea. And the cornea is sort of the window to the eye. Light pierces through it, and it hits the lens. And in conjunction with the lens, the cornea and the lens focus light onto the very back of the eye, which is called the retina. The retina is very unique in that it's actually neural tissue in the eye, and it connects to the brain through the optic nerve, which is the cable that sends everything back. The way an image works is it pierces through, just like we said, focuses on the retina. That signal is sent to the brain, and the brain is able to process that into what we see as our vision. Now, as you can imagine, this becomes a lot more complicated as you get into the pathophysiology of all of this. So this is an actual picture of a retina. And specifically, we're focusing on a very important part of the retina, something called the macula. This is important because even though it's a small portion of the retina, it's responsible for the majority of our vision. In the very center, you can see that little pigmented spot called the fovea, and that's the actual very central point of our vision. And everything that's seen and absorbed by the retina, all the signals are sent through the optic nerve, which you can see labeled there, which sends everything back to the brain. And you can also appreciate the arteries and vessels coursing through the retina, supplying all the blood supply. This is a normal and healthy retina, and we're going to see what a condition like macular degeneration looks like later. Age-related macular degeneration, or often abbreviated as AMD, is a degenerative retinal disease affecting the macula. It's the leading cause of vision loss in people over 50 years of age. 25%, so 1 in 4 of individuals over 70 years old are going to be affected by early or late-stage macular degeneration. By 2030, it's estimated that AMD will cause more blindness than diabetic retinopathy and glaucoma combined. So it's not only a big problem now, but we anticipate it's only going to get worse. There are 2 forms of AMD, often called dry AMD, or more formally non-neovascular AMD, and wet AMD, or neovascular AMD. The majority of people with AMD will have the dry form, 80 to 90% of patients. A smaller percentage will have the wet form, 10 to 20% of patients, but that small percentage is very important to catch and watch, something we'll also talk about a little bit later, because the majority of severe vision loss happens in those patients. There are many risk factors for macular degeneration, but the most important one is age, something we can't change. As we get older, our risk for macular degeneration goes up. But there are other components: family history, genetics, smoking, and there are things like smoking, lifestyle, diet that we can actually modify to decrease our risk of macular degeneration. So I promised we'd show you what a normal retina looks like and what one with macular degeneration looks like, and we're going to start getting into those images now. You can see labeled under normal a healthy retina. You can see labeled under drusen that there are all these fine yellow flecks and spots throughout what we described earlier as the macula. Those little spots are called drusen. Drusen are a buildup of waste products of the retina. Normally these waste products are formed and cleared, but in macular degeneration, they build up, and as they build up, they can cause damage to the tissue around them, which can lead to more advanced macular degeneration. In early macular degeneration, patients are usually asymptomatic. They often don't even know they have any symptoms. You can appreciate in this picture here that it's almost hard to see those drusen, those fine little yellow flecks right at the center that we call the fovea. They often have no vision loss at all, minimal if that, and it can even be tough to spot in examination sometimes. You have to look very closely. These patients can often live their life without any progression of macular degeneration, but it's important to watch them for the ones who will progress. There are sort of three stages when we talk about macular degeneration. We just talked about early. Now we're going to talk about the second stage, intermediate AMD. And this is where we start to really watch more closely. Intermediate AMD can develop symptoms. It can be visually symptomatic. It might be something subtle like distortion. Maybe straight lines are now wavy, no longer crisp. Maybe the very center of our vision is a little distorted and blurred. Faces look a little irregular. That can be early signs of intermediate macular degeneration. And you can appreciate these pictures that intermediate AMD has more significant drusen. You can see that they're either larger or they're just much more numerous. And so when we see this, we watch more closely because these patients are at a higher risk of progressing into the advanced stages of AMD. And there are two advanced stages of AMD, wet or neovascular AMD and dry or non-neovascular AMD. And you can see here on the picture a really advanced, untreated form of the wet neovascular AMD prior to a lot of the treatments we have available now, which we'll talk about in a little bit, and a massive kind of scar throughout the retina with very poor vision, unfortunately. You can also see on the dry, non-neovascular side a almost kind of cookie cutter-like appearance to that central irregular area in the macula, and that's an area where the retina has died off from chronic macular degeneration. To talk a little bit about what the symptoms are of advanced AMD, we talked about early and intermediate. In advanced AMD, there can be a significant reduction of central vision. Faces, we may not be able to see them. There can be a complete blind spot, significant distortion, contrast and color can decrease. These symptoms are often very difficult for patients, and they can affect things sometimes as little as just down to a couple lines of their vision, so able to do most things. But some patients with very advanced AMD may not be able to be independent. They may rely on others. It may be difficult to do even the most basic tasks. This is the natural history of the wet form of macular degeneration. You can see in the first picture that you can appreciate that area of drusen and those changes we spoke of. But as you progress through, if this patient was untreated, you can see that there's a significant amount of bleeding in the second picture. That's what all that dark and redness is in the center. And over time, that blood turns into scar tissue. And with each picture, there's significant progressive worsening of our vision. And this is a progression of the dry form of macular degeneration. Sometimes you'll hear the term geographic atrophy. It starts off with drusen in the early photos, and as you progress, the drusen grow and grow, and eventually that center of the retina dies off, forming that term, a geographic atrophy. In regards to testing for AMD, this actually starts at home. We have Amsler grids, which many people have heard of. It's a test you can use at any time. You look at the central dot with one eye and you close the other eye. If any of the lines seem to not be straight, if they appear wavy, irregular, or areas are missing, that's concerning for a possible macular or retinal issue. And oftentimes we tell our patients, if you've had any change at all, if you have any concern and you notice it on your Amsler grid, to come in so we can assess and see if maybe they're having a progression that we can slow down or treat. Another at-home test is the 4C home imaging. It's actually a sort of picture-based test that you look into, and it captures images in the back of the eye, and it lets the doctor and you know if things are changing, sometimes at such a small level that you couldn't even appreciate it. And so it's able to follow for very, very small changes in vision. And those are the two best ways people sort of follow at home. In the office, we have a couple tests we use. The most popular two are, this is one, a fluorescein angiography. You may have seen this before. We don't order it all the time, but we can, especially early on. It's a test that looks at dye coursing through the blood vessels in the eye. We inject the dye into the arm, and then we take pictures of the blood vessels in the retina. As the blood perfuses the retina, everywhere the blood goes, the dye follows. And if there's an area of the retina that's damaged or leaking, it will highlight with the dye. And you can appreciate looking at these pictures. These are actually separate eyes, but just to get an idea of what it can look like when it's normal. And then you can see on the left there what it can look like when there's macular degeneration in place. And so this is one of the tests that can point us in that direction. The one people are most familiar with often is OCT. It's a fast, easy, safe test. We do almost most visits in our retina offices because it's able to capture microscopic changes in the retina that can indicate that there is macular degeneration progression. And that's important for us to know because some forms of macular degeneration, such as the wet form, we have very good treatments for. And there are always clinical trials looking at potential new treatments for both the dry and wet form, which Dr. London will talk about shortly. And so catching any progression is critical, and this testing is exquisitely sensitive and able to catch very small changes. And you can see here a picture of a patient who came in and had this cystic space, this dark circle in the top picture. That was a sign that they had developed the wet form of macular degeneration. After one treatment, you can see that it's almost disappeared in the bottom picture. Now we've talked about monitoring, we've talked about testing. How do we treat this? Well, it starts with prevention, and we've learned that there are some things we could do to actually slow down or decrease the risk of developing macular degeneration. One of these is the AREDS2 vitamins. These vitamins were developed as a part of a large clinical study. It looked at what nutrients and factors would best benefit patients who have macular degeneration from progressing from the early to the later forms. And this formulation of vitamins has been shown to decrease progression and particularly can benefit people with the intermediate stage of macular degeneration. They're often available over the counter at most places, and there's all kinds of varieties. Diet is important too. You know, the AREDS2 vitamins are great. They're nutrients, they're supplements, but you can actually do this at home. Studies have shown that the Mediterranean diet decreases the risk of worsening macular degeneration. And the benefit of the Mediterranean diet is it helps a lot of cardiovascular diseases. What is the Mediterranean diet? It's a diet that consists largely of green, leafy vegetables, fish such as salmon, legumes, different kinds of nuts, and trying to cut down on significant amounts of grains or red meats. Eliminating smoking can also help slow down the progression of macular degeneration. And as we kind of alluded to earlier, managing high blood pressure or other cardiovascular disease is very important. Now, what do we have for treatment? Well, thankfully, we have a treatment for the wet form of macular degeneration. It was only about 20 years ago, less, around 2005, that we developed our first treatment for a wet form of macular degeneration. It involves injecting a medication into the back of the eye that aims to block the factors released by the sick blood vessels in the wet form of macular degeneration. This treatment can then almost, in a sense, shrivel up those bad blood vessels and decrease the risk of bleeding or swelling, maintaining vision for many, many years. Unfortunately, on the dry AMD front, we don't have currently any FDA-approved treatments. That being said, we have a lot of exciting clinical trials that are trying to develop the first one. Another thing Dr. Lin will talk about soon. Now, the idea of a needle in the eye is terrifying. I understand that. No one really wants to have a needle in their eye, but I can assure you the procedure is safer, easier, and more comfortable than you'd think. And it can do amazing things. To give you an example, the natural progression of wet macular degeneration before this treatment came out appeared as below. A patient went from very good, possibly 20/20 vision on the left to being completely blind on the right. But if you're able to catch the eye at the early stage there, early on in its wet macular degeneration course and treat it, we can shrivel up those blood vessels and control them and eliminate that progression, potentially maintaining their great vision forever. So in summary, age-related macular degeneration is the leading cause of blindness in people over 50 years of age in the US. The greatest risk factor for developing AMD is advancing age. Symptoms include decreased and/or distorted central vision. Wet macular degeneration can progress more rapidly than dry macular degeneration. And we have established treatments for wet macular degeneration, but we do not have established treatment yet for the dry form of macular degeneration. And at this point, we're going to pivot the talk into now transitioning to talking about some of the exciting new breakthroughs that might be on the horizon for macular degeneration. I think the really good stuff of this talk. And Dr. London's going to take over from here. Thank you for your time.
Hey, everybody. Can everybody hear me?
Yes.
Awesome. Okay, let me see if I can see myself. Give me 2 seconds to get this set up right. Mike, good job. That was amazing. Mike is he's sort of selling himself short. The guy's an all-star. He joined us last August. Am I advancing? Okay. This is okay. I can't see myself, but that doesn't matter. So Mike joined us he finished at Wills Eye Hospital in Philadelphia, which is where I did my training as well. Wonderful, wonderful place. I'm sure we both miss it quite a bit. Some of the real pioneers in our field are at Wills Eye Hospital. And Mike finished there in about July or June of this year and was supposed to start in September. And the guy's such an all-star. This is sort of just a testament to how he cares about people and things. I went on a vacation with my family out of the country, and while I was there, I unfortunately developed COVID, and my son developed COVID, so we had to quarantine there for about a week. Mike was still on vacation. He hadn't started yet, but I emailed and said, "Hey guys, I'm so sorry, I'm quarantined." Mike said, "No problem. Let me know when to show up." And he showed up and he saw, probably 200 or so of my patients and just, worked his butt off. So wonderful guy, wonderful person, and we're extremely lucky to have him here. He really epitomizes sort of what we think about treating patients and how we want to be a center of excellence. That was a great lead up to my talk. I'd like to kind of get into some of the latest and upcoming treatment options. And, this can get really complicated. So I tried to kind of hone it down. I wanted to talk about, of course, wet macular degeneration, which we're all most familiar with, as well as some of the new and potential treatment options for the advanced form of dry macular degeneration, which is really a frustrating disease. Mike and I are both a little too young to have been around in the days when patients used to go blind routinely from wet macular degeneration. That was a pretty rapid process, and that must have been an absolutely terrible experience, both for the patient and for the powerless physician. And that's a bit how we sometimes feel about advanced dry macular degeneration. We can watch patients and we can see them with progression of disease, and we know that we have nothing to do, and we help guide them to low vision services such as the Braille Institute, which is amazing. But other than that, we kind of are hand-holding most of the time. One thing we tell them, though, is that we're never going to give up. We're not going to quit, and that's sort of some of the things that I want to get into here is what we're trying to do. We're going to keep aiming at this, and I guarantee we're eventually going to get a treatment option for dry AMD. So let's get into the talk, and Mike kind of already addressed this. So we're going to start with wet AMD, which we call neovascular, for new blood vessel macular degeneration. And this is a left eye here with some hemorrhage in the middle of the macula with those drusen that Dr. Ammar mentioned earlier. And just like Dr. Ammar talked about, this is due to abnormal blood vessel growth. The whole reason people get wet AMD is they go from just having drusen, just having those little yellow spots, they're kind of like little cholesterol buildups under the retina. Those are kind of like having cracks in a sidewalk. Wet AMD is when you go from just having those cracks in a sidewalk to having little weeds grow through the middle of those cracks. And those weeds, untreated, unchecked, really destroy the tissue. They destroy the photoreceptors. They cause swelling. They cause other fluid accumulation. If they rupture, they can cause bleeding or hemorrhage, which can be very devastating. The good thing is we can inhibit these. So we didn't have this 20 years ago, but we do now. As Mike mentioned, untreated, it leads to a scar formation after a year or even less sometimes. And once you have that scar, we call it a disciform scar. There's absolutely nothing we can do for the central retina. That being said, this does not cause blindness. A lot of people are really worried about going blind. This causes central loss of vision, and it does not affect the peripheral vision except in very, very, very rare circumstances of extreme bleeding within the eye. It doesn't happen frequently at all. So people that have wet macular degeneration, with appropriate treatment, if they're caught early enough, should not fear total blindness. It's not going to happen. The main molecule here that's causing the growth of these blood vessels is called VEGF, for vascular endothelial growth factor, so growth factor for blood vessels. And this acts like fertilizer. This is a normal molecule. It's very important when we're embryos. Sorry, somebody just asked a question if the PowerPoint presentation is playing. Is it showing okay?
We're not able to see it.
You don't see anything?
We see
No,
you and your children.
we see you. You look wonderful, but can't see
gotta go.
your sharing. I don't know
I
if
gotta
you
go.
hit the button to share.
Da-da-da-da. You look great. Thank you. I don't know who said that, but that was very kind of you. Okay. So share content.
I just realized that you didn't know.
No, I had no idea, but that's okay. How about that?
There it is.
Perfect.
Yay. Okay, good. Should I start from scratch? Just kidding. Okay. So just an intro slide. I showed just a slide of bleeding in the central macula. And this is that cross section, that analogy to a weed. Wet AMD is like weeds growing through the cracks of a sidewalk. And we can get rid of those weeds just like you can spray those weeds with weed killer in your garden. They cause bleeding, and they eventually cause a large scar formation. And this is a picture similar to what Dr. Ammar showed of a disciform scar. Once you have that, there's nothing you can do. The main thing that's implicated here is called VEGF, for vascular endothelial growth factor. And this is a molecule that's very common. It's normal. It's an important molecule in our bodies, especially as we're embryos and developing. It guides blood vessels and where to grow, and it's a normal vascular homeostasis molecule. But in eyes with wet macular degeneration, diabetes, vascular occlusions or strokes in the eye, the concentration of this molecule goes from extremely low in a normal adult to extremely high. And just like if you threw fertilizer all over your garden, it would just wreak havoc. You might get weeds growing everywhere, and these blood vessels rely on this. And we didn't know until recently that we can get a sniper rifle and we can really reduce the concentration of this molecule in the eye. This is a graph from one of the pivotal studies, and it shows the change in vision over time in a clinical trial looking at treating wet macular degeneration with injections. And all the dots are each month and then monthly injections. The white line is the natural history. This is what used to happen. You'd start at that over on the y-axis way over there on the left, and then every month you just would get worse and worse and worse and worse. That's sham. That's what we used to have. And now we have these injections which not only will prevent that, but actually improve the vision. So most people get about a line, 2, maybe even 3 lines of improvement in vision once we initiate treatment. And so we can treat this. We've got great treatment, but what's coming next? So that's really what I want to get into here. So Genentech is one of the companies that's been very involved in developing great treatment options for eye disease, macular degeneration, diabetes, all sorts of diseases. And they've been pioneers in 2 now FDA-approved medications. And this is the first one. And some of you guys may have heard of it. I've got patients starting to trickle in that are asking about this, called Vabysmo. Vabysmo is a very interesting molecule. This structure on the right here, that's an antibody. So that's sort of what an antibody looks like. And the top portions are the portions of the antibody that recognize foreign material. But in this case, they've engineered those arms to recognize VEGF. And by recognizing and attaching to VEGF, it neutralizes VEGF and eliminates its activity for the duration of action of that medication. That's what the normal drugs used to do. Lucentis, Eylea, and Avastin, Beovu, all were anti-VEGF antibodies or receptor decoys, but the same action. Vabysmo adds one more thing. So it's a biphasic antibody, we call it. And it has two different targets. So it's got the one arm that will attach to and neutralize VEGF. We call it an anti-VEGF antibody fragment. And that's going to reduce vascular leakage, and it's going to inhibit new blood vessel formation known as neovascularization. But it has another arm, and it's this other arm that's novel, and this doesn't exist in any other molecules out there. And this is what's really exciting about this, is that this biphasic antibody also will neutralize something called angiopoietin-2, or Ang2. By neutralizing Ang2, we further stabilize blood vessels. We reduce leakage from those blood vessels and inflammation. Ang2 is an entirely different molecule than VEGF, and by neutralizing both of these in combination, we're really hoping that we get improved outcomes and improved durability. One of the main problems with our current medications, although they work extremely well, they need to be given very frequently. So the average injection frequency for a patient with wet AMD, it ranges everywhere from every 4 weeks at close to a minimum to every 3 to 4 months if you're lucky, but average is about 10 weeks, 8 to 10 weeks for patients. And so this hopefully is going to extend that. And it did. So we just are wrapping up the phase 3 clinical trials called Tunaya and Lucerne, looking at this drug. It was called faricimab. That's the sort of generic name of the medication. And about half of patients on every 16-week dosing, and 80% of patients could be maintained on every 3-month dosing, which is way better than what we've got before. So before, you got to about every 10 weeks, and this is getting half of patients to every 4 months. So that's already a huge home run, and this should be available within the next month. If any of you are currently being treated, you can ask your eye doctors about it. Genentech also recently has FDA approval for another device. This is called Susvimo. Susvimo is a surgically implanted reservoir. So there's a one-time small surgery. It takes about half an hour. I've performed it, and it's not a complicated surgery. And this little tiny device, about the size of a couple grains of rice, slowly allows the release of the medication into the eye. And this was also studied in phase 3 clinical trials, and also recently was shown to be highly effective. In nearly 100% of patients, they needed refills of this implant, which is an office-based procedure, every 6 months. So again, going from injections every 8 to 10 weeks, these patients with this surgical implant are getting treatment or injections every 6 months. It's a permanent device, and again, it's a fairly simple surgical procedure. The only downside being that it is a surgical procedure, and one thing that we as doctors like to try to avoid is going from treating a medical disease to treating a surgical disease, or making a medical disease surgical. It has its own set of risks, but this may outweigh those risks. We always think about the risk-benefit ratio. Another medication, so another study that we're highly involved in all of these clinical trials we've done here at RCSD, is from a company called Kodiak. So this company took another really interesting approach. You can see the animation on the right there. So they took the anti-VEGF antibody, so that little fragment that neutralizes vascular endothelial growth factor, or VEGF, and they took a large number of those. I believe it's 8 to 10 of those, And they attached these anti-VEGF antibodies to this biopolymer, which is sort of like a gel, or it looks, in this picture, it looks like a little octopus. And so you've got all of these little anti-VEGF fragments on there. And so with one molecule, you now have, greatly extended action. And this medication may last 3 to 5 times longer than current medications. So even longer than Vabysmo or faricimab, which we just mentioned. It lasts significantly longer than the current medications that we have, Eylea or aflibercept and ranibizumab or Lucentis. So we're very hopeful. We're involved in the studies and very hopeful that patients being treated can be treated every 4 months, 5 months, 6 months if we're lucky. And this would be with an injection into the eye as opposed to the surgically implanted reservoir. In their early clinical trials, nearly 80% of patients who were treated were able to go 4 or more months between the treatments. We're currently recruiting for ongoing trials. One of the sexiest things that we've got going on in clinical research for macular degeneration is with gene therapy. And I know a lot of you guys out there have probably heard about, read about gene therapy. It's been something that's been in the works for quite a long time, probably decades in development and decades in refinement, and it's finally coming into fruition. We actually have an FDA-approved gene therapy product for other blinding eye conditions, Leber's congenital amaurosis, and we're working on other things as well. REGENXBIO is developing gene therapy, which is actually going to engineer a patient's eye to produce the medications that it needs to treat these diseases. So before, when I was talking about these anti-VEGF antibodies, these fragments, these are all what we call proteins. And proteins are what cells produce. So cells in the nucleus will read out DNA and then RNA and then produce a protein as a result. So the whole concept behind gene therapy is that you introduce a very small snippet of DNA into the cells of an eye, and that little snippet of DNA will be read out just like the cell's own DNA. And by reading that out, we can actually get it to produce a new protein. And in this case, it's going to produce the protein that is this medication. So essentially, it's Lucentis in this case, which is the medicine it needs. So it's possible, and I fingers are crossed, but I don't want to hold my breath. It's possible that gene therapy is going to cure a number of patients from wet macular degeneration. And we have a lot of patients in these studies right now. This is a study that's still ongoing and still enrolling. So people with active wet AMD it's something that not everybody's going to be a candidate for, but if people are interested, they're welcome to contact me and I can give them more information. And this sort of shows what I was talking about earlier. So in gene therapy, you use what's called a viral vector. I know virus is kind of a dirty word these days, but it's a benign viral vector called adeno-associated virus 8 or AAV8. And this is a benign virus. It can't cause human disease. But the way a virus works is that it sort of looks like a spider with a body and then sort of legs. And the legs sort of attach to a cell, and then the body will inject a little bit of DNA into the cell. And in most viruses, like the coronavirus or whatever, it's going to inject the DNA that will encode for more virus. And so it gets the cells, it hijacks the cells, and it gets it to produce more virus. And then the cell, it disrupts, and then the virus kind of goes everywhere and makes a mess. But we can actually hone that process and change it so that benign virus, instead of injecting its own viral DNA, injects whatever we want it to inject. So in this case, again, the machinery of the DNA for Lucentis. And we hope that, by producing their own medicine, that we'll get a number of patients that dramatically reduce the number of injections needed to control their disease. This is a video, and I hope it plays well over the call here. But this is one of the ways that we inject the virus into the eye. So there are 2 ways that we can do this. We can either do a surgical procedure, and I'll play that again, where we actually inject the investigational product under the retina during a surgery, and I'll show you the video for that in a second. Another novel way is that we can inject this investigational product into the wall of the eye using a very short needle. This is a needle that's a little less than a millimeter, and it gets into the wall of the eye without getting into the eye itself or under the retina. And you get just a little bit of that medicine that then spreads just like that India ink spread in this transilluminated eye here. And again, the other way that we can get this investigational product into the eye is with a surgical procedure. So this is where we do a surgery called a vitrectomy, which is a very common surgery for us. And you see that little needle, it's actually a little cannula, and it just gently pierces through the retina, very gentle, and then you inject the product and you create these little blisters that we call blebs. And that's another way. And the company is looking at both of these methods for doing this and sort of looking at the pros and cons of each of these methods. And both are kind of active studies going on. The good thing is that it works. So we have initial trial results. This is a phase 1 trial results. Phase 2 studies are the ones that are ongoing. But in the phase 1 studies, we do see protein production. So, we always have to ask, is it working? Is it doing what we wanted it to do? And the answer is yes. So this shows protein production, so that anti-VEGF antibody production, both at month 1, but then it's sustained. And at month 6, you can see both those blue bars are pretty much the same. We get sustained protein production. And in these studies, in this phase 1 study, which was just of 15 or so patients, we've got 5 or more of them that after 3 years now have needed no more injections. So very interesting. This is something that I recently was privileged to present at a meeting in Chicago, and this is what we call swim lanes in our field. So it shows these patients. So there's 15 different horizontal lines here, and each of the dots for those 15 lines represents an injection. So those are 15 patients that are being treated with the various medications that we currently have available. And then at that black line over on the right, you can see that vertical line of orange dots. Right there is when they're treated with the gene therapy product. And after that is the number of injections that these patients, sorry, that's all message, but after that is the number of injections that these patients then needed. And you can see that the number of injections in the vast majority of these patients is quite a bit lower. And then, it looks like 5 of them needed no more injections following treatment with the gene therapy product. And overall, we saw about a 75% reduction in the need for injections after treatment. So this is sort of early phase 2 clinical trial results from these gene therapy studies that we're involved in. So that's wet AMD. So we've got faricimab or Vabysmo, which is on the market and should be available within a month. We have Susvimo, which was FDA approved back in December, on the market, should be available every 6-month refill surgically implanted device. We have Kodiak studies, which are looking at every 4-month injections, ongoing studies, and then we have gene therapy, as well as a number of different molecules. There are dozens of things being looked at, and all very exciting, very cool stuff. But let's pivot a little bit and go to geographic atrophy. So Dr. Ammar eloquently talked about how geographic atrophy is essentially death of a tissue layer under the retina. So if the retina is wallpaper on a wall, this would be like death or decay of the drywall underneath. And without that support underneath, without the retinal pigment epithelium underneath the retina overlying that can't function at all. These are total blind spots, and you can see them here in these photos. On the left is a color photo of a right eye, and you can see those circles in the middle of the macula. And on the right, they're much more obvious. Those black circles are areas where the retinal pigment epithelium, a tissue layer under the retina, has zero function. And that's why it's black here. This is looking at metabolic activity. And if you have no metabolic activity, that's a bad thing, and it's going to look black here. The problem with this is that these enlarge over time. And if it involves the very center, then we're in big trouble, and we're going to lose a lot of central vision. It accounts for about 10% of vision loss in macular degeneration overall, but a much higher proportion of untreatable vision loss. We can treat wet AMD, and we just went through some great treatments that we've got, and we can do absolutely nothing about this. And Mike showed this as well, and this just shows the progression. So it's a slow progression. This is over about a decade, and you go from the upper left color photo there with just drusen in this patient to the bottom right where you have that circular area of atrophy, that geographic atrophy in the circle there. Patient in the upper, same patient, but the picture in the upper left, that patient probably has great visual acuity, probably 20/30, 20/40. And in the lower right, it's maybe seeing the big E on the eye chart. So really much more challenging. The problem with geographic atrophies, we don't really completely understand what's called the pathogenesis, or what's going on here, what's causing this. But we do know that it involves something called the complement cascade. The complement cascade is the bane of a lot of medical students' existence. It's a very complicated cascade. It's this here. So imagine a second or third year med student or first year maybe, trying to memorize this and what all of these little things do. But the complement cascade is essentially part of your innate immune system. So when you first encounter a foreign pathogen that your body's never seen before, it's your innate immune system that kind of goes into action. It's the initial line of soldiers, and the complement cascade is part of that. Overactive complement cascade is like having overactive inflammation, which we all know that inflammation is not a good thing. So we've seen a lot of dysregulation in the complement cascade, and we've seen a lot of correlations between that and the development of macular degeneration, and specifically geographic atrophy. We've also seen genetic defects, so people that have defects genetically in the complement cascade, some of them have a higher likelihood of having macular degeneration. We've seen complement deposition, so too much complement being deposited under the retina in some patients with macular degeneration. And then the last piece of evidence is that we have a drug that finally showed some efficacy from a company called Apellis, where they inhibited the complement cascade, and they got about a 20% or so, 18 to 20% reduction in the growth rate of those areas of atrophy over time. So we know that it's involved. It may not be the only thing that's involved, but this is where all the money is going right now, is trying to help with this complement cascade. So we just talked about gene therapy for wet AMD, but we're also working on gene therapy for geographic atrophy, and a company called Gyroscope out of the UK is one of the pioneering companies here, and another study that we're involved in and very excited about. So this has to do with factors in the eye that cause amplification of that complement cascade, and factors that cause down regulation. So you got these molecules, and ignore the names, but C3b and CF complement factor B, those cause amplification of this cascade in this little seesaw here. There's another molecule called complement factor I that causes down regulation and normalization of the complement cascade. So this helps to regulate that overactive. And we've seen some patients with, again, genetic defects in complement factor I who have more development of geographic atrophy. So the question here, again, CFI, complement factor I, is a protein. So again, we can use gene therapy. Can we get the eye to produce more complement factor I, and will that help lower the progression of geographic atrophy? And that's being actively looked at. It's, again, a gene therapy study. In this case, they're delivering the investigational product through a surgery where we inject it under the retina. These are a couple of other studies that are going on. There are a couple really cool things about these, and again, most of them are looking at that complement cascade. On the left, we see Ionis. This is a company out of Carlsbad, actually, so very close to home. And they're looking at systemic inhibition of complement factor B. So we just showed that in that seesaw. That's one of the factors that causes amplification of the cascade. And so if you inhibit complement factor B, are we going to help here? And the cool thing about this is that it's given as a skin injection, so a subcutaneous injection. Instead of needing an injection into the eye, it's given into the, you just pinch the stomach a little bit and it's a tiny little needle. It's really easy. I've treated patients in the clinic here, and it's essentially painless. So that's really nice. You avoid an eye injection. I'm sure who doesn't love the idea of that, even though they're essentially painless. They're amazingly painless. But it also treats both eyes. So in patients that have bilateral atrophy, it's going to treat both eyes, which is wonderful. The downside being that you're getting systemic immune suppression. So the study makes sure that people are very up to date on their vaccines and other things, because you have a slightly suppressed immune system, which is not a small deal. So again, pros and cons. Annexon is another company, and they're looking at inhibition of a different molecule in that complement cascade. This is given with an injection into the eye. This is another study that's recruiting. And then back to Genentech, of course, they're working on this as well. And they're looking at a study called Gallego, which very similar to the Annexon study, is an eye injection. So in summary, and then it looks like we've got a couple minutes for questions if we have questions. And let me get my picture of myself out of the way. But wet AMD and geographic atrophy are both blinding conditions. We've got wonderful treatment options for wet AMD these days, and we've got better treatment options in the works. And I'm hoping that we have a cure for wet AMD, at least for some patients. Geographic atrophy we are working on. We've got one drug from Apellis that may be approved. It had a 20% or so reduction in the growth of those areas of atrophy, so those little circles that grow. So 20% slower could get you an extra year of good vision, which is not nothing. And better drugs hopefully on the horizon. And there's a lot going on, a lot of resources being poured in there. The main thing that I tell my patients, though, is that we never quit. We are not going to quit until we find something and make our patients' lives better and reduce the rate of blindness in our patients. I think both Mike and I are very passionate about that. And so with that, I'd like to thank everybody for their attention. We are both here to answer any questions. Feel free to write down, these are our work emails, and you're welcome to contact us if you think you might be eligible for a study and you're interested. I'm happy to give you advice there, or if you just want to ask me questions, I'm happy to answer them. Thank you.
Thank you. We want to remind our guests today that if you have questions, please utilize the chat. Write your question in the chat and they will be taken in the order received. I'd like to ask Bradley to help with that. So please, you'll need to write your question in the chat. Unfortunately, we cannot take any questions via mic.
And we also ask that you keep your questions relatively generic enough that it is not applied to any specific situations, such that it'll be beneficial to all attendees. The first question that we have here, does Medicare cover injections?
Medicare definitely does. So almost all of our patients that are being treated for wet mac. Can you guys hear me, first of all? Mm-hmm. Yeah. Okay, good. Sorry. I just kind of jumped in there without pausing to. But yes, Medicare does cover it. The great thing about these medications, they're very expensive. So these medications, I think some of them are about $2,000 each. Medicare, of course, covers 80% or the vast majority of that, and the secondary typically covers the rest. In patients where it's not fully covered, the companies usually have very generous programs to help cover any out-of-pocket costs. And we try extremely hard to get our patients' out-of-pocket costs as close to zero as we can. I really bug my staff every single time I'm seeing a patient. I say, okay, I'm about to give this patient an injection. What is it going to cost them? I want to make sure that that is zero, if at all possible. If it's higher than zero, then we talk about other options. We do have a medication called bevacizumab, or Avastin, which is a very common injection that is, instead of $2,000 per injection, $50 per injection. And it's not an FDA-approved medication, and it never will be. And it has a couple minor-ish drawbacks, but it is effective and safe. good question. My email address, somebody's asking, is London, London, at RCSD, Retina Consultants San Diego.com. And Mike's is Ammar, same thing.
We will send that out to everyone too. We have your email address, so we'll share that information with you. Bradley, looked like there was another question there for the doctor in the chat.
Indeed. I'll briefly also say, I see some folks with their hands raised. Again, we're only taking questions from the chat. If you do have questions, I'm sure they're fantastic. And if you're not able to enter them in the chat, it is admittedly a difficult place to find. But as Dr. London did just share his email, you will be able to reach out to him as well that way. The next question is, are there any research trials for dry macular in Los Angeles area?
Yes, yeah. So all of these trials in most large metropolitan areas are going on, and actually, it's very ironic because the best practice in Los Angeles is the website is LA Retina, great group. Dave Boyer is the head of the practice, and the ironic thing is that my college roommate from UCLA is one of the retina surgeons there. It is an awesome practice, and they are absolutely doing a lot of these dry AMD trials. I've even seen that they were doing one trial for dry AMD even without atrophy, so just the drusen. I don't know where that stands, but yeah, Boyer, Boyer, is the head of the practice, and their website, LA Retina. Great group.
And that's laretina.com. Wonderful. Thank you. We have one more question that's here so far, but if there might be a time for a couple more. Two more coming in. First, is there an age limit on entering clinical trials on dry AMD? My mother is 97 years old.
It's a great question, and for the most part, no. A lot of trials, put an upper limit around 89 or so in most trials. I think most patients have to be between 50 and around 89. But for these dry AMD trials with atrophy, there's typically no upper age limit. A lot of the patients with it are in their 90s. So I think if they did put that limit there, they wouldn't enroll any patients in the trials. So no, I think.
Wonderful. And perhaps time for this last question and maybe one more, but any research into transplants for late stage AMD? So,
it's a wonderful question, and yes and no. There is research. People are working on things. Our colleague that Dr. Ammar mentioned, Dr. Ann Hannikin, she has a bench research lab at Scripps Research Institute. She's a brilliant physician and investigator. She's working on sort of retinal rejuvenation kind of. I don't want to put words in her mouth, but she's working on things there. There are wonderful surgeons out there that have done things called macular translocations, where they actually will detach a retina and rotate it to get a healthier part of the retina where light is focused, where the macula was. There currently is no such thing as a macular transplant, where you take a donor retina and put that healthier tissue there. Unfortunately, once this neural tissue dies, it doesn't come back. So it's just a challenging thing. And then getting all of those connections to reform would be very challenging. For some other blinding conditions, we are working on retinal implants. So they actually have electrode arrays that we surgically place onto the surface of the retina that stimulate the tissue and bypass some of the diseased portions, and we can get some vision back, even from no perception of light to some vision where you see sort of vague shapes. Mike, anything to add there?
No, I agree. I mean, I think for a long time, people thought there wasn't going to be anything in regards to dry AMD, but regardless of age, and I'm often surprised by the criteria. A lot of people will qualify for these, and there's a lot of great options.
Any other questions? These are great questions, guys. Thank you.
Wanda, do we have time for one last question?
One last question, Bradley.
Thank you.
We're not going anywhere.
Can stem cell therapy treat retina scarring? And this might be a different sort of question, but.
Mike, you want to?
Yeah, no, it's actually a really good question. And it's something that people are looking at and have been looking at, especially for the dry form of macular degeneration. As Dr. London spoke about earlier, one of the big issues with the dry form, that geographic atrophy, is he made that comparison of if you had a wall and the drywall was eaten away and all you had laying over it was the wallpaper. Well, what if you had a way to go back in and put the drywall back in place? Would you then have a functional wall? Would you then have a functional eye? And so there is research looking at the possibility of putting in cells into the spot of the old cells, new stem cells, and seeing if, one, they can kind of attach themselves there and stay alive, and two, if they do, can they actually respond and improve the signals, the visual pathway, the electrical signals. And those clinical trials are very early on. The technology is very early on in its time, but it's very exciting and it's very innovative, and it is something people are looking at.
Well,
Anything else, Nick?
No, I agree. Yeah, we're very excited to be. We've talked to the people that are pioneering that work as well. It's given with a very similar injection of the stem cells under the retina, like those videos that I showed, and we've talked to the people pioneering that. And once those come into fruition, I'm really hoping that we get involved in those as well and can offer those to our patients in the community.
Wonderful. We're at the 2 o'clock hour. I want to give a huge thank you to Dr. London and Dr. Ammar for taking time out of their busy schedules to share their expertise. And Dr. London mentioned Dr. Ammar as an all-star. Well, Dr. London is an all-star as well. This is Dr. Ammar's first presentation with us, and we appreciate it. Dr. London has done multiple presentations over the years and has been a good friend. A good friend of Braille Institute. So thank you to both of you. And thank you for all who have joined us in this informative seminar. As a reminder, this presentation has been recorded and will be posted on our Braille Institute YouTube channel. And again, we'll send all participants a follow-up email with our presenters' contact information, the contact information for our low vision services, and a flyer with some of our other low vision seminars we're presenting for the month of February. Thanks again to everyone, and hope you all stay safe and healthy. Thank you.
Thank you, everybody.